Good afternoon, ladies and gentlemen, friends and colleagues. On behalf of my co-chair, Professor Eric Eckhout, he has to wake up early in the morning this morning to participate in this second live case of the day. And it's a very interesting case of a severely calcified lesion. So we can see what our team at the National Heart Center will do to treat this patient. Maybe I can have the panel members shown if possible. Very happy to see our great contributions from Dr. Ashok Seth, President of the APSIC. Thank you so much for participating with us. Dr. Maurice Bookbinder, a very old friend of ours. Again, thank you so much for coming with us. And of course, Dr. Wasan from Thailand, excellent interventionist, CTO expert. Dr. Takashi Akasaka, a well-known imaging and physiology expert and interventionist, and of course, our good friend Dr. Paul Ong from Tan Tock Seng Hospital. So without further ado, we will move ahead to see what the live case is about. Let's go to the cath lab.
Hi.
Okay, KK and Philip, you're live on air.
Hi, good morning everyone. It's a real pleasure to have you with us here at Sing Live. Let me first of all introduce my team. I've got Prof. Philip Wong here with me, Chi Yang, who's the imaging expert we have that will comment on our imaging results, and then Charity, our nurse, who will be supporting us for this case, and of course everybody else in this room here. So with that, I'm going to hand over to Philip, who will discuss this particular case that we're going to be doing today. Philip, over to you.
Good afternoon, and Prof. Ko and panelists, and good afternoon, Eric or good morning, Eric from the cath lab. So today we have an interesting case. He's a very young gentleman, 50 years old, who presented in September to our outpatient clinics with symptomatic chest pain. He was actually listed for a functional test, but before he got the functional test, he actually was admitted again for acute coronary syndrome. And at that time, cath was immediately done for him. You can show the cath images. We'll quickly go on to show the cath images. So he's got basically a left dominant system. And if you look at the the left coronary system, you can see that the LED has got a very tight lesion in the proximal LED. Just at the first diagonal, and you will notice that it's extremely calcified from the proximal to the mid segment. Now, if you look at the left circumflex, there is also a mid circumflex lesion. FFR was done at the time of diagnostic angiogram to both the LED, and FFR to the LED was 0.43. FFR to the circumflex mid lesion was 0.83. So that was the situation at the time, and he now presents for PCI or other strategies to his coronaries.
So, well, it's a wonderful thing to see all of you in this live program, and I think many of us have known each other for some time, so it's always good to see friends on the panel. We know that you won't ask too difficult questions. With that in mind, maybe I'll just ask if maybe I'll just show the angiogram today and then ask the panel for their opinion. So we can go to our live X-ray images. So these are oops, sorry. These are the the baseline images. This is the Prof. Ko, you can see the pictures?
Yes.
Very clear.
Okay, so we'll let it run by, and then maybe y'all can comment on it.
Wasan, you want to go ahead and give us some comments?
Yes. Yeah. Okay. Yeah, this is looks very calcified at the proximal to mid LED, and significant stenosis in the LED by the FFR. So I think we will treat this LED, but for the circumflex FFR is more than 0.8, so maybe we can leave that alone. So with the LED disease like this, I think if we can see the imaging like the IVAS, may be helpful to assess how about the extent of the calcification, and also is there any eccentric or maybe calcified nodules that is maybe difficult to perform the PCI and to select the device. Uh, I think if we have the imaging, may be good to the discussion later.
Ashok, what do you think? This case is too straightforward for you. I think you're mute, maybe.
In the meantime, I agree with you. This is the best way to take care of the LAD proximal. You could decide where to do it with a rotoblader or perhaps an IVL, which is very much possible given the calcification and diffuseness.
So I can come in now. I'm sure you're able to hear me.
Yeah.
So in the past, when we see such calcified lesions, and there's a heavy eccentric calcification angiographically on that bend close to the first diagonal, I would have said, before we had the multiple tools, I would have said, the moment you think rotational atherectomy, do it. Of course, now we got multiple tools and we have got an imaging algorithm, but I do find that imaging algorithm not useful in all patients, and therefore I do believe, for example, we could say shockwave, but we would have to pre-dilate prior to shockwave. I think it's great to see on imaging whether we got circumferential calcification nodules, or eccentric calcification. We got to consider whether we use a rotational atherectomy followed by a shockwave, which is absolutely okay in such situations where we have eccentric calcification, and may use a guide wire bias of rotational atherectomy to ablate first, so that the balloon, shockwave balloon, can then actually approximate the calcium better. So I think imaging is important for us to decide three modalities of balloon dilatation followed by shockwave, rotational atherectomy followed by shockwave, or rotational atherectomy.
Will it be important to look at the IVAS as well to this discussion? Will it be helpful?
Yeah, very helpful. I think it's the advantage of IVAS, of course, is that you don't need contrast. I think everybody's excited about OCT, but
Yes, that's exactly the point.
it's something that people tend to neglect. And in long procedures, OCT, you may end up by using a lot of contrast. And but we didn't hear the strategy of KK, what the intention is, because we see you working, but maybe you want to go back quickly to the operators to, maybe we can ask Dr. Akazaka for some advice, because of course he will give us more information about which imaging technique to use.
Yeah,
He is
yeah.
one of the world's top experts in imaging.
Thank you very
Very
much.
lucky to have him here.
Thank you. Yes, yes. We can identify the lots of calcium, eccentric calcium, especially by angio. It might be stay on the myocardial side, but location in the calcium identification is very important. How to treat this region. So anyway, we try to use an imaging device first, but if it is not pass, we have to do the ablation to pass the IVAS or OCT. But, there are some discussion about the IVAS and OCT, but if there are no kidney concern, I highly recommend to use an OCT, because we can check the thickness of calcium and the position of calcium really well, right? So, but any kind of imaging, it might be okay to identify the calcium position. Yeah.
Very important to understand what we have before moving forward. So this is, we all seem to agree that IVAS is very important to begin with.
So let's maybe go
So
back to the
thanks very much for the
operator
comments. It's again wonderful to hear everyone's voices. I think the comments are about the same ones that were our minds as we prepared for this case. So let me show you what we have done a little bit ahead of time. So we put a wire down and then try to advance the an OCT into the vessel, which did go, but not surprisingly, the contrast would not cross. And you know, that being the case, we proceeded to pre-dilate with a 2O balloon at low pressures, and I think we appreciate the bend and the in the calcified area of the prox to mid LED. With the once we performed that, we were able to do the OCT, and I think this is a good time for me to hand over to Chi Yang, who maybe will do a quick commentary on this, and then I'd like to hear what the panel thinks about the OCT run and how it would inform your strategy. Over to you, Chi Yang.
Okay, thanks. So this is the OCT run. It was a 54mm high resolution pullback. So the proximal, the edge of the pullback, like, does not cross the circ ostium. So here we are in the ostial LAD. So this is the fat part, I guess, in the ostial LAD, which is, there is diffuse fibrotic disease, but lumen there was otherwise not compromised. Here the disease starts. You can see some ossification here from about 2 to 7 o'clock. This part, maybe a bit less calcium, just a small chunk further down. This is still within the proximal part. You can see the angio code registration on the top left-hand corner. This white little rectangle tells us where we are in the vessel. So a lot of, there is eccentric calcium, but it's not superficial calcium, it's deep calcium. So there's a thickness, there's a thick fibrous tissue between the lumen and the calcium. Around this part is the tight part that we see on angiography with eccentric calcification. On OCT, the calcium is not very well seen. It should be down here. There's a lot of thick fibrous tissue in between, so maybe that's limiting our ability to visualize the calcium. Nonetheless, down here we start to see a little bit of this low intensity signal, which is consistent with calcium. So yeah, so there is diffuse calcium throughout this LAD. If you apply the OCT calcium score, at some parts the calcification is, I guess, more than 180 degrees. The calcium length is long, and the calcium thickness at some parts does exceed, such as here, does exceed 0.5 millimeters. So if you take into account all these criteria, then this is a very calcified, heavily calcified lesion. All these points predict a difficult lesion to predilate, and by virtue of the fact that the calcium is located deep, rotational atherectomy or other types of atherectomy strategies may not be effective in modifying this calcium.
So thanks very much, Chi Yang. That is really, you know, when I looked at OCT images, it's like a box of chocolates. You never know what you're going to get. So I was a bit disappointed that there's so much deep calcium. But really, what does the panel think? I mean, I'll be keen to hear what Professor Akasaka has to say.
Yep.
Maybe we can also ask Paul Ong. He's one of our panelists who didn't hear before. Paul, are you there?
Yeah, very good.
Yeah. I think this is a great case, KK. The fact that you've done the OCT and you've got all this information, I'm just curious what we will do next, because I think you now have opened up the artery, you've dilated it, and whether you still would need rotational atherectomy is really debatable now. I would thought, based on this image, I would probably go and dilate this vessel even further and see if you can open up. And any spot that you cannot open up, I will probably default to lithotriplasty and use shockwave to deal with that selectively.
So can I come in here and something? You did the right thing. I mean, I would have done an OCT, but there's a thought process that I always have when I have committed myself to shockwave. And I do believe that shockwave works better if you actually not just pre-dilate for the sake of getting the shockwave balloon down, but also if you actually rotoplate some of the heavily calcified eccentric plaques, then you have a better approximation of the shockwave balloon to the deep calcium which we want to fracture. Now and the second aspect is that you have a larger larger incidents of balloon ruptures when you put in a shock wave in a compressed form where it hasn't expanded enough for the emitters to actually not to create the force through the solution rather than directly affect the balloon material. Now we've had shockwave ruptures, IVL ruptures, when we've actually put it in undilated vessels where the shock balloon is collapsed and starts emitting. So I'm very clear that I would perhaps have done rotational atherectomy and then imaged it and then gone in with a shockwave, but I think now you're committed to dilating and going with an adjunctive technique if you want.
That's the guy. I personally agree with you that rotablator could be the first approach, followed by IV. So this is very important because you can have calcifications that are behind you and creating a bigger problem and not expanding well.
Yeah, so the cheapest solution would be to pre-dilate and hope for the best that these very performing new non-compliant balloons can lead the way. Or you go for a combination of FLOTA followed by shockwave. We had a shockwave rupture this week. I think we're all learning to use shockwave. I think before it was just a holy grail and it would solve everything, but we encounter, trackability, we encounter rupture. How you are going to deal with a very long calcified because you're only allowed for 80 shocks, and how you're going to deal with tapering because the balloon has to be adapted in a 1-to-1 ratio, and an LED is so much tapered that there are so many technical considerations in a long LED calcified lesion to consider with shockwave. So it's not always the holy grail. I don't know what you think about that.
Now, Eric, I'd comment on that and also tell you that the balloons we have at the moment are thin material, the one which is used in CAT3, or the thicker material, more resistant balloons. In Europe, you only have the thin material, maybe hopefully the thick material balloons of IVL in a month's time. But the more you actually push it along a long lesion and calcified lesion, and more you drag it back along calcified lesion, you hurt the balloon material more. And that's why you sometimes see the ruptures happening on the 6th and 7th side.
I had the rupture I had on Monday. Basically, I put my guide extension on front of the lesion. I advanced my balloon, inflated it, ruptured at 4 atmosphere.
Right. We've had that as well.
That's exactly what happens.
Maybe you can ask Dr. Akasaka on his comments on the OCT and what strategy you would suggest. I think you have experience with IVL in Japan, right?
In Japan, IVL is not available at the moment. We are now trying to do the approval trial, right? So privately, I have only few cases, but anyway, there are still tight region, and it might be very difficult to pass the shockwave balloon at the moment. Therefore, anyway, we have to do the ablation, right? But some part looks like the total plug is very eccentric somewhere, right? And we can identify very normal region here as well, right? So 9 o'clock. Therefore, I highly recommend to change the wire to the rotablator wire, and then try to, if possible, it depends, but if possible, try to pull back the OCT again to check the wire bias to avoid the power, right? Or you try to use a small size of rotablator such as 1.5, right? Yeah. Otherwise, there are some complications.
That's what we discussed earlier, that maybe to start with the rotablator and follow with whatever we want with IVL maybe is the best way. And we will not have the complications that we have seen already.
Yeah. Yes, I think Dr. Akasaka point out a very important point about the guide wire bias for the rotablator. So if we can see from the imaging that the wire bias is against the calcium site, then we are safe not to have more complications. If the wire bias is against the normal tissue, then we may have the problem. So when we see this imaging or kind of this imaging, we can avoid some complications and have a better result.
We can go back to the live
Thank
again.
you.
Philip, you are using a balloon, I
Yeah.
think. Very simple.
So I must say that's a
Okay, can
really
you hear us?
fascinating discussion.
Can you hear us?
Yes, I can.
We see you are
hear us?
dancing in the place, so probably you're about to balloon.
Yeah,
there.
can you hear us?
Yes, yes.
Okay, good. So I must say that the discussion is really an eye opener for me because the same thoughts occurred, but when Philip and I planned this case, we actually were concerned about eccentric calcium, but it was also deep calcium. So we actually thought that maybe a primary shockwave treatment might work better. And we figured that if really there is residual waste despite the shockwave, then we might advance to a rotablator. It's a bit of the inverse of what I think Maurice and Ashok was saying, but I think we think that it's a reasonable try. And if let's say this 4 atmospheres inflation of the shockwave balloon didn't work, then I think it would speak volumes about the extent of calcium. So I know that's not what you all had recommended, but let's see how this goes. So this is the shockwave, a trio going in. Give me a bit of slack.
It is most appropriate. What you are doing is also appropriate.
We are very curious.
Thanks, Maurice.
Okay, Kate, have you
So I
pre-dilated? Have you
cheated-
dilated the vessel a little bit more since the IVUS, or this is after IVUS? After OCT immediately gone with the shockwave.
We had done a 2.0 earlier on, and you can see the little bit of the guide backing out, and I'm a bit paranoid here. As with many things in life, the best laid plans don't always go according to plan. So this is the shockwave balloon, sort of very gingerly and grudgingly going through the lesion, but it did go through. So I think this is where there is substantial calcium, and you can appreciate if I just adjust the wire a touch. You can appreciate the underlying shelf of calcium at the inferior curve of this vessel, and I'm just going to see how it goes with the inflation now. So the system is on. We'll go to 4 atmospheres.
Very well done.
This is 3.0, so it's a large vessel. And I think straight away you can appreciate the calcium. And then we are activating the shockwave.
Support wire or just a regular PCI wire?
Oh, this is just my favorite BMW. Okay, so that's 10 shocks going down. So what do you think of that?
So what
I'm
size
sorry?
of a shockwave balloon have you got here? 3?
Yeah, 3.
Right.
We were more worried about the prop, but I know it's a bit big for the distal vessel. So
Yeah, so it's-
I'm going to pull back a touch because just to make sure the guide and the wire are both okay. Okay, so let's go to
This
4
can work in
atmospheres
an
again.
LED, but we're not in a circle and in a right, just right.
So that's where you have the highest level of what seems to be the eccentric calcification.
Okay, we're down again. So that's another 10 shocks.
And you do realize
Okay, maybe you can show the
The console,
console.
the machine.
Yeah, so this is the inflation. And you can see that there's still a constraint on the vessel. I'm going to go one more time here, and then I think let's go up to 4 again.
Camera to point on the console of the shockwave.
So just for those who
Sorry.
early
It's a
users
bit
of
tight. It's a bit tight.
shockwave,
We can't turn it.
it may be better when you see the eccentric calcification to deliver more pulses,
Safe.
more cycles at that particular point. Still use the waste disappearing and then bring the balloon back in a long lesion, because it would be very difficult to push the balloon forwards on multiple occasions than it is to bring the balloon back. So
Yeah, that's exactly it.
Nice teaching.
Increase. We do it a couple of times more.
yeah.
So, Ashok, if you have, because you have 8 runs, if you have to decide on how many the worst calcium, how many runs could you go? At least 3?
So I would do 3 here and then bring it back.
Yeah, okay.
Max of 80.
Yeah, but but you can choose. You can. you have a long calcified segment, so you have to distribute your number of shocks along the trajectory of the LED. And that's always a difficult, I know, a difficult decision, but sometimes you shock too much where you shouldn't. And then, or you have to take a new balloon. You have to take a new balloon. Huh?
That's correct. So that's
It's always a bit difficult when you have the eccentric calcium as well, isn't it?
yes.
Yes.
It will never go away to nil, and that's the whole issue around it.
You have, and usually you have to do more than less.
Yes,
The other,
correct.
You see?
the other
That's
thing
the problem.
is guide extension and shockwave is not always compatible. Depending on the type of guide extension, it will get stuck into your guide extension.
The other thing, Eric, I would also, because I've had shock to balloon ruptures when they go through guide extension, and in the first instance, and if I feel that it's, I very carefully watch it entering the guide extension. As you know, that's where it sticks on occasions, and that's where the balloon material is thin and can get hurt. So it's actually the balloon material and the emitters which fire on a thinner balloon material, which actually causes the rupture.
It's not a luxury probably to go for 7 French and a 7 French guided for shockwave. It's probably safe.
Not much.
If it's a complicated case.
Correct.
You see some ST elevation, KK and Philip, during the procedure.
Yeah. Safe. So this is the last.
Do you think it's more
The
7 French also, you said?
sorry.
If you would do guide extension, but otherwise not.
Eric said 7 French of guide because of the decreased friction between the balloon and the guide extension. Is that right, Eric?
That's correct, yes.
Yeah.
That's right.
I think
It's safer.
Yeah.
It also depends on the type of guide extension you use. And this is
It
the
may be
brand.
favorable from rupture.
Okay, let's go up here. Okay. 6.
And certainly if you have a second wire like in a diagonal, then guide extension and shockwave and fixed flange is not compatible.
Is there any issue with the guide wire, the extra wire? Does it interfere or increase the accuracy of the cracking?
Nobody knows.
Haven't heard any wire fracture because of that, right?
No. Interestingly, did you all read about a recent report of ventricular fibrillation happening because of these electrical impulses going on a T phenomenon, and a case report of that happening?
Yeah, we read that recently.
Yes.
We're doing a classic cruddy.
Okay, we did a shockwave this week and we heard the ticking inside the patient. That was very strange. I don't know what was going on. The pulse is staying out of the body. I'm not joking.
So in terms of doing shockwave for the left main, is there an issue? Because I think your Disrupt 3, Maurice, in US, it didn't involve left mains, right?
No, I don't.
It did?
In fact, Disrupt 3 had very simple cases. And actually, the shockwave around the world, it actually happened in more complex lesions. These are not the lesions in CAT3, as you know. The lesion length was small. And the delivery of the balloon, de novo, was as high as 93, 94%. So you can imagine those were not. They were simple.
Left main,
So osteals and left mains and all were exclusions in that.
always been a little bit of a problem.
Yes.
Save it.
So if we were to do left main lesions, what kind of balloon size you think we would need? Or do we need to? Like,
3.5 to 4.0.
3.5 to 4.0.
Yeah, 3.5 to 4.0 always works better.
Yeah.
So you're going to image again, Philip and KK?
Just for the
Yeah.
audience, I wanted to bring one
Yeah,
more
so we are
point
putting
which
in the
Eric
IVUS,
raised.
I mean, sorry, the OCT again. I think you all saw that the shockwave did, segment did work, but the distal segment didn't work as well as I like, or mid distal segment. So let's see what it looks like, and maybe I can use a non-compliant balloon to just sort of the mop-up work. But the imaging will certainly be very helpful.
So I just needed to bring in one. Eric, you raised a very important point when you asked about the wire. And I have got into a habit, especially for long calcified diffuse disease segments, to use a more supportive wire for multiple reasons, and not just to get the shock wave balloon down, but understand the eventualities of getting various devices down even. For example, you may need an ultra high pressure balloon, which is again, requires like an OPM requires it to be on a better support wire than one of those ported wires. The ability, if you have a perforation, to get a covered stem down. So I actually just go up front with a more support wire, which gives me the ability to deal with any eventualities that I actually have, including delivering these bulky therapeutic devices.
So what do you use, Ashok?
I use an All-Star regularly.
Wow.
And
really supportive.
Yeah, it is supportive, especially if you use radial. It actually tracks everything down it. Great comfort, because I have a spectrum of cases where after shockwave, I have ended up using OPMs. And that's a spectrum of cases where on the imaging, you know that there are underdilated areas, and then you go up to the
You wire with it primarily, or you exchange over like a fine cross or something?
Either way.
2.5.
After I've rotablated, I would actually then put a fine cross down and change to a.
So you're going to look at the OCT now?
Yes, so we just did the OCT run. You can see it on the Cine as well. So again, Chiang, take us through it, please.
You can look at it again.
Doing the okay, all right. So we'll go from proximal to distal. Yeah. So this is here at 9 o'clock.
Yes. It is very important to put the CX to the 8 to 9 o'clock, because upper side is a epicardial site and the bottom side is myocardial site, right? So it's quite easy to understand the distribution of calcium.
Don't prep yet. I got it. So when you're go ahead and have a look at the OCT while I continue a bit of this work.
Okay, so these are the areas that were shockwave.
This is 10 or 15.
You can see a lot of dissections, obviously.
It's an explosion, and basically, it's a vessel.
That's part of it. That's how it works.
Yeah, but at least it works.
Yes.
Yeah.
It's not the moment to lose the wire.
Yes. Yes.
Oh, heaven forbid.
Yeah, I cannot identify any calcium fracture, but there are a lot of dissection. But still, some nodular calcification. So if you try to put the stent, it might be better to abrade that portion.
Right. Yes.
Right now, you're ballooning with a non-compliant balloon, or?
This is an angioscope 2.5.
And
So, I do want to comment on the 20. Sorry, Maurice, I missed that. Could you say that again?
I said I'd be worried about doing it right now after before stenting. I'm not sure it is fully done. And maybe rotoblader.
Yeah, I know.
Still be...
I think
so we have a bit of
a lot of dissection. So maybe if we do the rotablator, maybe there is some risk for the complications if we do the rotablator in the dissection like this.
Globally, to my humble impression, I think stenting will be fine, because we basically did the job. The calcium will be disrupted.
Yeah, I'm just curious. You used a 2.5 angioscope. I mean, your shockwave balloon was 3.0. Really want to see the fully expansion of the balloon. Didn't you choose something a little bit bigger?
Yeah, actually, you're right, Paul. That's exactly what we're going to do next. I chose a 2.5 because the mid segment after that septal, I wanted a 2.5, and then I just kind of worked my way backwards. But the next balloon is indeed a 3.0 angioscope. So we'll take that, and then we'll see whether that has a better result. 3.0.
Ask a question to Philip and to KK concerning the focus force balloon, like
Yes, Eric, I missed that. No, could you repeat that, please?
Yeah, there was a point to draw something.
3015. Yep. What did you say?
Sorry, we can't hear you.
Yeah, there is too much noise. I don't know what. Yeah, now it's better. So, but you use a lot
now
of
it's
these
better, yeah.
focus force balloons, like Andrew Sculpt, NS Alpha, Wolverine. I hear that you went up to 20 atmosphere. I think for Wolverine, I would not go to high pressures. What is your
That was an angel sculpt, I think, isn't it?
Andrew Sculpt? Yeah.
So
The question is, do you use a lot of Angel Sculpt and other plug modifications?
I do use quite a good number of these plug modification balloons. The one that I've a good amount of experience with is the Angel Sculpt, but I also use the Wolverine and the Scoreflex. I think it depends on the lesion. I have another wire in there, so I'm a bit disinclined to use the Wolverine in this case. So we'll see whether the Angel Sculpt is able to dilate that segment of the vessel right after this diagonal. I think the headache that we all would have to deal with is what.
I'm just going to comment.
Is what happens if we can't.
So
yeah, how much you go, like 3.0 or greater than that?
This is a 3.0.
3.0 only, yes.
Yes, the distal vessel, or rather the mid-distal segment, I use. Oh, be careful.
The thought process.
The mid-distal segment, I use a 2.5.
Sorry, rotational atherectomy was because there's an eccentric heavy calcification out there. We know that. I don't think any further balloons, whatever pressures you go to, are actually going to alter that calcification. At the end of the day, you'll actually just have to look at the minimal stent area rather than expansion, rather than get rid of that eccentric calcification.
Yeah, I think you're right. Ashok, I suspect that that
beginning may be helpful and easier.
You're right. I'm actually quite a fan of rotablator 1618.
Still waiting.
No.
What pressures is
But
that?
20.
You know, KK, Maurice Bookbinder was one of the first to publish on rotablator many years ago. Correct?
Yeah, I know Maurice from my time with.
Yeah.
Absolutely.
No, I know Maurice.
That's another century, basically.
Exactly, before.
Maurice. I trained with Reggie, so I know you very well. Yep.
I think I learned rotational atherectomy from Maurice in 92 or 93.
Exactly.
It was Maurice and basically Michel Bertrand, the French colleague.
Correct. Correct.
Correct me if I'm wrong.
You're absolutely correct.
Okay, let's take a stand. So just now, I think I know that there is sort of some constraint on the mid segment. It's not perfect, but as been discussed, I think it is unwise to rotablate now with all the dissection, and given the loops and the even nature of this lesion now, I would actually prefer to just start laying stents, at least in the mid segment. Would any one of you want to rotablate at this point in time?
No.
No.
So how much
No, huh? And, yeah, so
29, right? 2529.
So the length, give me a test.
You want a 2529?
Yeah, I think we'll put a 2.5 in there. The length is
Length is about 55.
the length is about 55 according to Chiang. Oh, I think there's a dissection
just
flap there, so maybe not so wise to push this wire, huh? Is it?
Smooth?
No. Talker for me, please.
Talker.
So yeah, we lost
May I ask
the well, not lost, but
yeah. Before, if we don't have the little tipsy balloon or the shockwave balloon. In this case, before shockwave balloon, in that situation, what did you prefer?
The poor man situation, you can use the OPN balloon.
Correct.
You don't have anything. But I think you have to be careful with OPN balloon too. This can have trouble. I don't know if this is the impression also for the other panelists. I tend to go to even for the atmosphere. But if you do that, your balloon and your wire will become one solid piece. So you need to put a second wire parallel.
Understand. Give me a 2529.
To put back your OPN balloon on the wire because it really gets stuck on the wire.
So
I saw Canopy had the same problem.
that's right, and that's why I use the All Stars regularly for heavily calcified lesions because it's European. And on an All Star, it does not stick on every other wire at 40-45 atmosphere. But I would also like to point out, and you're right, Eric, rotational atherectomy up to a 1.75 Burr, followed by an ultra high pressure balloon.
Yeah.
But you know, ultra high pressure balloons, if size, say if it is a 3, are safer than putting up, say, a scoring balloon to 20 atmospheres or putting up a non-compliant balloon to 28 atmospheres, because at 35, at 35, a 3 millimeter balloon OPN expands less than a non-compliant balloon at 25 atmospheres.
I think indeed
I think we agree with. I am totally agree with you.
I'd like to ask Dr. Akasaka,
Yes.
you know, when you are dilating these calcified lesions without the advantage of rotablators or IVL, just using plain balloons, there's always an increased risk of perforations and ruptures.
That's right.
Is there a specific size that you think that is optimal to reduce the risk of rupture? Because recently I had one case that didn't turn out well.
It depends on the case, but yes, the position of the calcium is the identification of the position of the calcium is very important. That is the reason why I recommend to rotate the image. And if the calcium-free site is epicardial site, we have to reduce the balloon quarter size, right? But the calcium is epicardial site, we can dilate using a bigger balloon, right? It is very safe, right?
But if it's concentric?
Yeah, if the concentric, we always use yes, a cutting balloon or squatting balloon. It's quite safe to make a fracture. Making a fracture, it is very easy to put a stent and dilate bigger using a non-compliant balloon finally. Yes.
Thank you. Spider for me. Center for me.
So you're doing a tremendous job with the case. May I just comment that I may have actually taken I would have taken a longer stent because I don't like overlaps in underdilated segments. You had the maximum calcification at that eccentric point, and now you have also an overlap at that eccentric calcified point. I would have preferred slightly longer stent so that you actually could have a better option of an overlap at another site.
That's for me.
What is going to be the most underdilated area in that case?
Yeah, you know, I agree with you. This is 29.
The most important part is to see what the calcification is going to be a problem with. That's why I'm interested in.
No, I think it will go down.
Okay, does the patient have any symptoms?
No, he's comfortably sleeping. Without sedation, of course. You know, I lost wire during one of the transitions. I know I've got not much time left, so maybe we'll just put another stand. Do you have what's below a 29, 26 or 24? That's too short. Do you have a 28 or somewhere? So this balloon, this wire here, this stand here is right at the just proximal to the diagonal, and you know, with the post stenting, you can see that it is extending into it. I'm thinking of a 26, yeah? 26. You have a 26, no? Okay. Maybe a trio 26. Give me something else.
Trio 26.
Yeah.
Okay, about 9 minutes.
Give me a.
left.
It should be
Okay,
fine.
we'll lay a stand there, and then I'll see whether I can fish that diagonal out.
Yeah.
Yep, Onyx is
The patient has
fine.
those symptoms. But the diagonal is slightly coming back. You look.
Yeah,
Do you think it's
well, we
important
hope
to
it
put
comes
the
back.
diagonal now with the stand?
A trio.
Try to put it by itself first before you finish with the stand in the LED.
Open.
Open.
Maurice, I missed what you said.
Would you be able to try with the diagonal first before you finish with the stand in the proximal to mid LED? It may be
You know,
very
I
difficult.
thought of that, but I'm a bit worried about the haziness of the proximal LED, and I think if I were to land this stand, it's just with one stand over strut overlay with the first stand proximally, I would be able to avoid the diagonal ostium. It's a bit of a risk, and but I think the LED is a bit more important at this point in time.
Sure.
So it's going to be a bit of a measured risk.
It's depending on symptoms, I think.
Stand boost, please. Okay. So I think we definitely have overlap there. We'll just use stand boost to guide us.
You're working in the 7.5 closure or images are excellent.
The low floral settings. And then I think we'll just check the stands overlap here. I'm going to check. You ready, Edwin? Ready? Okay, let's try again.
There's no overlap. Yeah.
So I think there's definitely overlap. A good amount of overlap, as a matter of fact. I think too much for my liking. I'm going to pull back a touch,
Come back a
paying
bit,
attention
yes.
to the spider view. Test.
Okay, you should come back a bit.
Don't be too
Yeah,
severe.
it's coming back now. Test.
Okay.
Okay, so save that. Let's do the stand boost proximally again. Okay, ready?
You saw that it a bit distal a bit.
I think we definitely have overlap. Maybe just 2 stand struts. I think that's acceptable, huh? Let's take a Cine biplane, please.
Excellent.
Ready? You know, I'll take this. Although on the cranial view, it doesn't look as nice as I like. I think I'll come back a touch more.
You can come
Oh,
back.
too much, huh?
You have space
Test.
proximally to come back.
Yeah, just about back. A bit more minute.
The test. So I think jump back.
Check your spider.
The spider may not be.
It always
I think the
really
spider may
is-
not be the best view for this test.
No,
Okay, let's
they
take a
always
picture
have the
here.
same impression.
But that's okay, leave it there.
But
Okay,
I
let's go up
also
here.
find out that if
Well,
you
all
put
of you
the
say it's
step,
okay.
the first
Test again.
hand is up on the left. You could move back and then
let's
you
go up.
end up at the same
Okay,
place.
going
You
up.
put it at the-
Up. 12.
12.
So KK and Philippe, what is the plan for the circumflex?
The FFR was all right, but we might want to repeat it with IV adenosine rather than the intracoronary down. We're down
Patient had heart block.
with the intracoronary, yeah.
Yes, that's correct. I remember that.
Okay. Yeah. Okay. We'll do a bit of post dilating and then maybe just do a OCT run for y'all. I see a hint of the diagonal, so I'm somewhat hoping that it will still be there. Let's take a picture here.
That's pretty good.
So I think it looks decent here.
Back.
Bit,
Let's post dilate first. A trio NC. So I mean that you can see that the calcium in the mid segment is still there, but you know it doesn't look too constrained. I kind of
much better.
suspect that yeah.
It definitely is very good, but the question again, how do we start with? That's my question, and we'll talk about it in a second.
Yeah.
Yeah, I think if I had to do this
That's true.
again, I might take out my favorite weapon.
Now, if I,
But
you know,
I think
at my center, I would actually, at this stage, would be imaging it and then using an OPN ultra high pressure balloon, because that would be safer than your non-compliant.
okay, let's go here. Sorry, Ashok, could you say that again?
Use OPN.
You
I
use
said,
OPN instead of NC?
Correct, because I find it safer. It expands less at high pressure
Oh.
than does even a non-compliant.
No, we haven't seen that.
Okay, so just to give you the statistic, the non-compliant balloon at 25 atmospheres is equivalent in size to an OPN at 35 atmospheres.
Okay, down. Monoplane frontal.
You can see the calcification. Still, there is some disease. Improved clearly, but still, let's see how it's gonna be.
Okay, down. So I mean, I think all of you are right. You know, there's still that calcium there, and I might have to OPN work, and this balloon won't go any further. But we'll do the rest of the post that. Let's go up. A trio OPN. 20. Yeah, down.
Yeah, you can see it in the mid.
Okay, up.
It's a very difficult valve. It's quite a bit.
No. One of the difficult part about this particular kind of disease is that, stand boost please, is that once you have committed to a strategy, the rescue options, I think very favorable comments made that we should maybe start off with a preemptive rotor. Bit of pistoning here. Let's try one more time. Yes, go.
You, I would suggest to you is after this, image it, because you're going to go by the MSA now, not just by the visual eccentricity at that particular point.
Okay, uncollimate. Well, okay, let's do that. Let's image first.
And may end up,
That's a good idea.
Very good.
we often keep chasing eccentricity and rupture a vessel. We'd rather look at the MSAs and be satisfied with that. Otherwise, it's just going to grow on the opposite side.
At that point, you are already impeded. That's it. You have to stop from continuing.
Well, I think that's a good point. So with some nitro, and then we're just going to image one more time. And then I think that will put us in a good time. No pressure, just 3 minutes left. Give me slack, please.
You can go fast. Not say anything.
Must compliment you on
Oh,
a
what's
truly
that?
illustrative case. I mean, there's so much to learn from this case, so much of this, and beautifully done. So have to
Beautifully
compliment
done.
you on that. Beautifully done.
Absolutely, I agree with you.
Oh, thank you.
Fantastic work.
So we're coming in with the OCT again. Let's see whether it can navigate down. Sometimes it gets caught struts. Usually happens when you have 3 minutes left. So what do y'all do when you have this? Yeah, give me a bit more slack. Let me just change the trajectory a bit.
Oh, only 1 minute left. Yeah.
Show us what you want for
These
the
guys
last.
are.
The image is blocked, Prof. Ko.
This OCT just won't cooperate
You
with me,
cannot see.
What's the connection, I think?
Yeah, I know. I was just saying that the OCT doesn't want to cooperate with me.
Any
Yeah, I think it's just stuck in that spot there. What would y'all do? Anything else other than a guide liner of some sort? Well, we can't get this down any further than that spot. That usually tells me that. Yeah, leave it. Yeah.
Leave it alone.
Let's see what it looks like after the final angiogram.
Exactly.
Is
Now, biplane on.
what do you think?
Really good.
Good enough to leave alone or go chase it with an
There's
OPN?
one area, the specules, is there, but I think it's not bad at all.
Yeah. What do the rest think?
We don't see anything big.
I'm actually keen to just leave it.
Yeah, you see it here, but I would think it's very acceptable.
I think using the rotovator, I don't know how much more you can optimize it.
I think it looks really
Other
good,
comments?
Yeah, I think it looks good. You'll image it, you know it, that it's got a good MSA, and I think that's all fine.
Well, very nice result.
Yeah.
I totally agree.
Wonderful.
Thank
Go
you.
forward.
Yeah.
Well done.
Okay, all right.
Great job.
Okay, thanks very much.
Congratulations.
Thank
You
you.
need to unmute, Popko. We don't hear you. Popko.
Okay. So thanks very much, everyone. Thanks, Philip.